Dysplasic epithelium is recognized by the loss in the uniformity of the individual cells and in their architecture orientation. Dysplastic cells exhibit considerable pleomorphism and often possesses abnormally large hyperchromatic nuclei. Mitotic figures are more abundant than usual and frequently appear in abnormal locations within the epithelium. In dysplastic stratified squamous epithelium, mitosis are not confined to the basal layers where they normally occur but may be seen throughout the epithelium. In addition, there is a considerable architectural uncoordination. For example, the usual progressive maturation of the tall cells in the basal layer to flattened squamous on the surface may be lost and replaced by a disordered hoggy patch of the dark basal appearing cells. When dysplastic changes are severe and involve the entire thickness of the epithelium, the lesion is referred to as carcinoma in situ. Pre-invasive stage of the cancer. It is important to appreciate that dysplasia is not synonymous with the cancer. Mild to moderate dysplasia that do not involve the entire thickness of the epithelium sometimes regress completely, particularly if initiating cause are removed. However, dysplasia is often noted adjacent to the frankly malignant neoplasm. The cigarette smokers with a lung cancer are in general the presence of the dysplasia marks a tissue as being at increased risk for developing an invasive cancer. Local invasions. The growth of the cancer is accomplished by progressing the infiltration, invasion, and destruction of the surrounding tissues. Whereas some benign tumors, as cohesive expansile masses that remain localized to their site of the origin. Because benign tumors grow and expand slowly, they usually develop a rim of the compressed fibrous tissue. This capsule consists of largely of extracellular matrix that is deposited by stromal cells such as fibroblasts, which are activated by hypoxic damage to parenchymal cells resulting from the compression by the expanding tumor. Encapsulation creates a tissue plane that makes the tumor discrete, movable, and readily accessible by the surgical insertions. However, it is important to recognize that not all benign neoplasms are encapsulated. For example, the leoma of the uterus is dissectedly demarcated from the surrounding smooth muscles by a zone of compressed and attenuated normal myometrium but lacks a capsule. A few benign tumors are neither encapsulated nor discretely defined. Lack of the demarcation is particularly likely in benign vascular neoplasms such as hemangiosis, which understandably may be difficult to excise. These exceptions are pointed out only to emphasize that although encapsulation is the rule in the benign tumors, the lack of the capsule does not mean that a tumor is malignant. Sadly, because of their uncivilized nature, tumor cells sometimes do not follow the rules set by human. We will see such deviations many times in this chapter. Next to the development of metastasis, invasiveness is the feature that most reliably distinguishes cancer from benign tumors. Cancer lack well-defined capsules. They are instances in which a slowly growing malignant tumor deceptively appears to be encased by the stroma of the surrounding host tissues, but microscopic examination reveals tiny crab-like feet penetrating the margin and infiltrating the adjacent structure. This infiltrative mode of growth makes it necessary to remove a wide margin of surrounding a normal tissue when surgical excision of the malignant tumor is attempted. Surgical pathogenesis carefully examine the margins of resected tumors to ensure that they are divided to cancer cells. Metastasis is defined by the spread of the tumor to the sites that are physically discontinuous with the primary tumor and unequally marks a tumor as malignant, as by definition benign neoplasms do not metastasize. The invasiveness of the cancer permits them to penetrate into the blood vessel, lymphatics, and blood cavities, providing opportunities for the spread. Overall, approximately 30% of the patients with the newly diagnosed solid tumors, excluding skin cancer other than melanomas, present with the clinically evident metastasis. An additional 20% have adult hidden metastasis at the time of the diagnosis. In the general, more anaplastic and the large primary neoplasm are more likely is metastatic spread. but as much with the most rules there are exceptions. Thank you so much for watching the video. Keep watching, keep supporting.